President, Professor Parezanovic, and the title of his presentation is Challenges in Estimation of the Common AV Septal Defect Surgical.
Thank you, Professor Kalangos. Dear colleagues, after some surgical topics, I would like to analyze the AVSD surgical repair, but from the pediatric cardiologist point of view, by analyzing our single-center experience in University Children's Hospital. As we know, the complete AVSD is one of the common congenital heart defect, which is very often accompanied with Down syndrome and very often with moderate to severe congenital congestive heart failure. In some cases, severe AV valve regurgitation started even in a fetal period, so we have several cases with a very early onset of the heart failure, even in the first days and weeks of life. So which you will see later, which needs surgery very early. Over the decades, surgical techniques have been changed, but the main goal is to operate those kids in infant period relatively early, just to stop the progressive of heart failure signs. Usually, the single stage operation is recommended, but as I said before, in some cases, especially in premature babies with huge regurgitation, we needed to do two steps with the first one with the PA bending, but it's really rare today. The surgical repair is very effective, but the grade series show the mortality rate up to 2 to 3%, and reoperation rate 10 to 15%, mostly due to residual regurgitation on the left or right-sided AV valve. For this purpose, this study, we decided to use the total performance score, which is widely used semi-quantitative method for estimation of severity of residual problems. It's relatively easy to use. It counts three echo parameters: residual insufficiency on the left-sided AV valve, residual VSD, or residual ASD. So if the kid after surgery has mild or no residual regurgitation or VSD or ASD, it means he is in a TPS group 1, which means it's very good or perfect results. While if the patient has severe, for example, only one of these parameters, it's enough that, for example, have severe residual mitral valve, left-sided AV valve regurgitation, and no residual VSD and ASD. This put this patient in TPS group 3. Also, if there is any of right-sided outcome, for example, fatal death or permanent pacemaker or reintervention, any of these events will put patient in TPS group 3, even those kids, for example, no severe residual problem. So during the last 20 years, we analyzed 81 patients with complete AVSD, but we excluded unbalanced AV canal accompanied with tetralogy of Fallot or in complex heart defects in heterotaxy. As we analyzed the age at surgery, median age was 8.5 months. with two-thirds of those patients operated in the first year of life. Almost all, 96% of our patients had, before the surgery, had really severe heart failure signs with ROS class 3 or 4, which means that the failure to 3 was really presented. You see the body weight Z-score was minus 2.3, and more than 50% of our patients had also Down syndrome. After, sorry, I missed one. Mechanical ventilation median was 1 day on mechanical ventilation, with 30% with the prolonged mechanical ventilation. Median stays in ICU was 4 days, and the death happened in almost 10%, which was really surprisingly for us. I will tell about it later on or more. Permanent pacemaker needs 4 patients in the same hospitalization. We usually, after a postoperative block, wait for 2 weeks for recovery. If they didn't recover, we put a permanent pacemaker. Reoperation due to bleeding we had in 2 patients, and other reoperation, early reoperation in 5 more patients, and while late reoperation was happened in 11% of cases later on. As I said, when we finished this study, it really was surprisingly for us this high mortality rate, is almost 10%. For example, in our clinic for, I don't know, tetralogy of Fallot or arterial switch operation, the mortality rate is less than 3%. So we were surprised why was this happened, and tried to analyze all of these 8 patients. And we saw that except one, all of those were operated in age less than 5 months. Some of them even in an age of 2 or 3 months. One of them, you see, was premature baby. The mortality didn't have any connection with the Down syndrome or severity of heart failure before the surgery. Most of them died in the first few days after the surgery due to low cardiac output syndrome, or probably due to post-pericarditis cardiogenic shock. I need to say that we at this period we didn't have opportunity to put those kids on ECMO, so probably the mortality rate probably will be much less than we had. Only two of them died in, you see, 17 or 27 days after the surgery, and they had signs of severe pulmonary artery hypertension. After the surgery, we performed this TPS score for all patients, and you see the 1/3 was in the TPS 1, 40% in TPS 2 group, and 28% in TPS 3 group, included those who died or had reoperation or pacemaker implantation. When we compared those 3 groups, only in age of this we had some significant difference, which means that in TPS 3 group the median age was lower than the other 3 groups. As I said, it doesn't matter if it is Down syndrome or not. Also, we tried to see if the condition before the surgery had some influence on outcome, and also didn't find such connection, because as you can see, even in the best group, TPS 1 group, most of them had ROS class 3 or 4 before the surgery, so the pre-op condition doesn't have a significant impact on outcome. Also, after the surgery, of course, patients in TPS3 groups has a longer period for mechanical ventilation, prolonged stays in, on ventilator and ICU, and increased late reoperation rate. At the end of the study, we analyzed 68 patients because 8 dead and 5 lost in follow-up, and we saw that only 10 of them, which means 15%, has in TPS3 group according to the residual problems estimated by ECHO. But the most important for us pediatric cardiologists is the quality of life. I think you will agree that it is not so important if the patient has residual left-sided AV regurgitation +1 or +2, but very important is how does it function? Can he or she play a sport or have a therapy? It's good that in our group only 15% has still heart failure with the ROS 3 or 4 class. All other are without therapy. Early reoperation has 7, 2 for bleeding and 5 for residual problem, mostly left AV valve regurgitation. And late reoperation also mostly due to residual problem on the left AV valve. Only one patient need resection of subaortic stenosis. And in the end, our freedom from of reoperation was, as you see, 84% after 5 years and 72% after the end of the study, which means that 3/4 of them doesn't still need reoperation. In conclusion, I want to say that complete AVSD is operable but challenging congenital heart defect. The main residual problem is left-sided AV valve regurgitation. The rate of early reoperation has been decreased in last decade. Even in our clinic, we now have a policy to have a transesophageal echo in every single operation, every single surgery. So the rate of early reoperation was significantly decreased. Mortality rate in our population was unexpectedly high, but I'm sure that the use of ECMO could significantly improve these results. Optimal timing, we can discuss it, but it's important not to be too early and not too late. And overall long-term follow-up results are quite good with an acceptable number of patients who doesn't need any therapy or any other surgery. Thank you very much.
Thank you very much for this nice presentation. Now we will open to discussion the session. Yes, please. Your microphone, please.
Hello?
Yes, no, I switched on.
My name is Vladimir Milovanovic. I'm a pediatric heart surgeon from Belgrade. I work in the same hospital as Dr. Parezanovic, and I was involved in, I would say, a number of these cases. And we first saw this paper maybe 1.5, 2 years ago. Not the paper, but the results. And I must say that we were all shocked by the numbers, and I didn't expect this kind of mortality at all. After all, I would say that we made a huge difference in the last couple of years, I would say 2 years, because we started doing a transesophageal echo for all the patients that go in the theater. And I would say that it made the biggest difference in these patients with AVSD. because as Professor Kalangos mentioned, if you're not happy with the regurgitation, it's not going to get better, it's going to get worse. So AVSD is, in that sense, good for transesophageal echo, because if you are not happy with the regurgitation, you can go back and do something in most of the cases. As for the mortality rate, I think that we didn't have death in the group of the AVSDs, at least for 4 or 5 years. And it's very difficult to speculate the reasons of the deaths of those 7 patients. Overall, we don't now like to operate them if they're under 3 months of age, and we are aware that we have to operate up till 6 months if we are talking about complete AVSD. But nevertheless, I would say that just in this transesophageal echo, I think it's going to hugely improve our results, not only on the survival of the patients, but of the quality of the predominantly left-sided AV valve. And also one other thing regarding the reoperation, we saw that if you have a small ASD residual, it's going to get bigger and bigger. So it's also change of the policy. If we now see the smallest residual ASD of millimeter and a half, or 2, we would go back on bypass and close it.
I will have the first question. I have my impression, you are in favor of early extubation, especially, in those cases with pulmonary hypertension, in Down syndrome. Why you don't want, to prolong a little bit the extubation time? There was, some influence in the results of this early extubation.
No, it's difficult to judge now. But
Do you use systematically nitric oxide in these cases?
Yes. I don't know, especially in the last couple of years. Mm-hmm. But now we have, as Professor Parezanovic mentioned, we have ECMO, so we would have now a chance to give them a chance, at least. But it's very hard for me to judge what would be the reason for that high mortality rate, because after all, if you have, I don't know, I think that there are some data regarding the cross-clamp time. It's now for the AVSD, regular cross-clamp time is between 50 and 65, 70 minutes, so we don't have a problem with the prolonged operation. Nevertheless, as I told you, I think the last patient that died from the AVSD was like 4 or 5 years ago.
And what is your preferred technique? Is the single patch in all cases?
We were trying one way or another. For example, with a single patch technique, with the Australian technique, we had, I think, 2 AV blocks. Mm-hmm. So basically now, if we have a large ASD, we would skip it. If we have a small ASD, we would consider a single patch technique. But otherwise, I would think maybe 80% of the patients with complete AVSD are going to have a 2-patch technique.
Yes, because it depends also on the depth of the VSD. If you have the length of the VSD is more than 7 millimeters, usually, I prefer the double patch technique in order, to enlarge also the left ventricular outflow tract and avoid, an imbalance in the new mitral valve. Because with the direct closure of the VSD, the anterior annulus, goes down with the stitches. And this one also can create an imbalance at the coaptation zone of the leaflets.
I have just a comment. I'm Željko Đurić from Croatia, cardiac surgery. Mm. So in your study, I mean, it's a great study, but I think you look at the period of 20 years, and in our institution, if you look at the period of 20 years in AVSD, the mortality would be the same. Our mortality, I think, I don't know the numbers, but I think the mortality really dropped since we are using TEE and always TEE in the operating room. We use NO. We use double patch technique mostly. I think the AVSD can be quite challenging and complex lesion from multiple aspects. If you have a bad valve and you start with a bad valve, then it's quite hard to get it really competent. I mean, you can use the posterior enlargement with a patch and even, anterior, a kind of the between the patch in between the zone of opposition. I use the homograft patch for that. If I wanted to kind of the patch cleft augmentation, if you want to use that technique, it's really nice. But then again, even if you have a good valve, we had some mortality regarding sepsis and the problems in the ICU, which were not predictable, even before surgery. So I think this is a really complex lesion, and if you operate too late, then the pulmonary hypertension will slowly be a problem. If you go too early, the tissues are bad. So I think the question is of era of operation. If you look at the maybe last 5 years, I don't think the mortality would be 10%.
Yeah, yes, I just thank you for this comment. Yes, probably if we put the last 5 years, it will be completely different. But we started this study, just wanted to see the rate of reoperation after, I don't know, 10 or more years, and then we surprised about this mortality rate. So for sure it will be decreased in the last.
There's also one interesting issue that I think you mentioned it. The rate of the regurgitation is not going to be necessarily linked up with the status of the child 5 years after surgery, because in my mind, when you have a regurgitation of +1.5, +2, it's a severe problem. But I followed up some of my patients that were operated, for example, 5-6 years ago, and they're completely clinical fine without any medications in ROS group 1. And on the other hand, there are some patients with a smaller regurgitation initially after the operation that are clinically worse than you would expect. So there's so much things that I still don't understand regarding the follow-up of those patients.
Yes, Professor Marek and then Petrov.
I think it's not easy to make some summary. So certainly we have a good cases, we have a bad cases, and I think we need to spend some time discussing the patient, what would be the best approach for the patient where we decide to going ahead. First, sometimes we can optimize the circulation. This is always important because it's better to put the child on the NG feed and use the anti-failure medication and keep him to let the tissue grow. You can't do it in all patients. So then considering the bending, when would you consider the bending? So there's also, we should still keep it in account that we can palliate before taking over. Of course, if we have the severe AV valve regurgitation, we can't bend. Then optimizing the circulation is very important before and after. So if we have the patient who more likely develop the pulmonary hypertension, all these patients, we leave the residual atrial communication because the post-operative management is much, much easier. So leaving the small atrial communication, why not after the repair if you expect the patient, because sometimes we have the patient's late referral from overseas to Great Ormond Street Hospital. So we see the large variety of the patients. Next, the kind of the classic approach. If you have the unbalanced AVSD, so one of the options with the borderline left ventricle, and we know that it's AVSD, it's not the borderline LV in coarctation or aortic stenosis. Why not to close the atrial component and leave the ventricular component? because you optimize the circulation, you promote the left ventricle to grow. So there are the several options to consider, and so the surgical planning is extremely important. Of course, if you have the late referral and it's the Down syndrome, so then, in fact, in the Down syndrome, the anatomy is much better, right? Because they are typically rastery C, they have the very good quality of the tissue. So why not to do them sooner rather than later? Because they potentially develop the pulmonary hypertension. So I think the planning, again, borderline left ventricle. So you guys surgeons, you can borrow the tissue from the right side, right? So you can put the asymmetrical patch or two patches to borrow the more tissue to ensure, particularly if you have the deep scope. So sometimes it's difficult to put the ventricle patch in the right position, but you can borrow the tissue from the right side to create the larger orifice for the left ventricle. So there's always a lot of thinking, and this is also the experience. And you mentioned you mentioned that if the left AV valve is bad, so then there's the much less chance that what you can do. So then again, you can consider, so can you replace the left AV valve? And we should spend really the time investigate early outcome in theater and do everything possible during the first run of the bypass or during the second run of bypass. Try to do the best at the time of the first surgery, because then if you leave the chart and there's the severe left AV valve regurg after, you consider redo. So these are the worst patients. So to spend the time and to everything to make the valve as good as possible during the first operation. So these are kind of the rules. Putting the prosthetic valve, that's the other option, of course, but you need to understand that the minimum of the orifice is the 16 millimeter that you can put the smallest prosthetic valve. That's also applied for your mitral valve repair, right? So in some patients, when we struggle repairing the dysplastic mitral valves in the small baby, so then the remaining option is to put a transcatheter melody valve, hybrid procedure, surgical and transcatheter. So there are options, but the best always is to have the best planning when and how to treat.
Thank you very much, Professor Parezanovic. My name is Sergei Pric. I'm a pediatric radiologist from Belgrade, Serbia. I have actually two questions. The first one is about timing for surgery. You showed that your median time for surgery was 8.5 months. In your opinion, what is the most appropriate time? Because in our institution, it's a little bit earlier. And Professor Zhang told maybe some changes in muscles of the vessels in the lungs can appear during the time. And second one is we had one patient a few months ago who finally finished with mechanical valve. My question is for surgeons, can replacement from the pulmonary valve to the mitral valve position can be considered in that cases?
Thank
Something
you.
like Ross, but on the mitral valve.
I will answer on the first question. Yes, this is the second result that surprised us, that only 2/3 were operated in the first year of life. Our policy is to do all of them surgery, of course, in the first year of life. So, but not before, as Vlada said, before 3 months, if we can. But in some cases, we have some good, in 2 cases maybe, good results with early surgery in maybe second month of the life, but usually between 3 and 6 months is our policy in the last 10 years.
Yeah, I will reply regarding, the Kapani approach, those 2 surgery. Sorry, the mitral valve replacement, using the pulmonary autograft. This one is good, in big children, not, in very small. In very small, I agree with Professor Marek. It's better, to use a melody valve, or sometimes in some cases, I use this smallest contegra. I put, inside the Gore-Tex tube, like, the Cabernet approach, the ROS2 surgery. Because the problem you have, to use a Gore-Tex tube, and this Gore-Tex tubes, creates a lot of adhesions. There is no place, and sometimes, you create a left ventricular outflow tract obstruction because it's too long, really. And then the other handicap is that in these cases, if there is pulmonary hypertension, the annulus of the pulmonary ring is too big, to adapt, in the small mitral annulus. There is, too big disadvantages of the ROS2 surgery in this case. Yes.
Yes.
Oh, sorry. Yeah.
I'm Andreas Petropoulos, and I would like to give another focus on this discussion of the intensivist, the cardiac intensivist approach. Now, what happens in this very complex condition is mostly because we don't know the genotype of each patient. And today we know that many patients have a genotype that is more favorable to early pulmonary hypertension than the general population. And I'm not only discussing about the patients that are trisomy 21, and we know very well the reasons why this happens to these patients. But generally, we see now and then patients in the general populations, neonates, even without heart defects, that have an element that looks like a primary component of pulmonary hypertension, and you cannot deal with it. So one reason is we don't know the genotype of all these patients, and this can explain why some cases of AVSD, although well treated, do not have the same good result. The second is what Professor Marek said. When we bring these patients to the theater, we must be able to have the best condition of these patients, nutrition-wise, electrolyte-wise, best even hemoglobin, so we will deliver after a smooth operation a post-operative period that will have less complications. And the third thing I would like to emphasize is the anatomy, because in the job we do, two things are very important: anatomy, size, and time of the operation. So when you have a very large ASD component, you have a very much stressed, overloaded right ventricle. If this is also related to a bad left AV valve that has a huge regurgitation, these patients have two elements of creating two different types of pulmonary hypertension: post-capillary from the left AV valve and pre-capillary from the volume overload of the right ventricle. So I believe that these patients need to be more closely studied before you go to the surgery. And regarding the timing, I believe that what Professor Marek said, some cases to be staged by a PA band, is a very good approach, mostly in countries in where we are not having the amount of surgical capacity we need, with more patients and more physicians and more equipment, so we can have the best outcome. So staging the patients with the PA band, I think, is a strategy we must keep in our practices nowadays. Thank you.
Yes. There was a question.
Meanwhile, I just, to answer on the last comment, in our series we had only two PA bands, and both really helped, because both newborns was with very severe heart failure, and also had a huge PDA. So we performed PA bending, closed the PDA, and later on decreased the signs of heart failure. In 6 months, we do the complete surgery, but only in 2 cases. We avoid it, especially, as you said, in a huge regurgitation.
Just a couple of comments. For PA band, personally, I don't like it because when you come back and operate, there is a lot of hypertrophy inside the heart, and it's really hard to fix anything. So if you can avoid this PA band, then I think if you can do earlier surgery, then it's fine. If it's too early, then okay, PA band is okay. The other comment is, I think it is important to kind of find a way how to biologically replace the valve, the mitral valve in kids. And Roscabani thing is, I think this is a difficult surgery. I have never done it. I do Ross, but Roscabani, I never did it. I think you have to have a big left atrium, or at least big enough to put this tube inside. And of course, you can have LVOTO after the surgery. So I don't know about Roscabani, but the other concept that adult surgeons in 90s they did mitral homografts in a mitral position. So I would like you, if you can, Professor Kalangos, comment on that. I mean, you're a mitral expert in this region. In the post-Carpentier era, they did a mitral homograft in mitral position. And the other question would be, we have problems with the neonates who are AVSD, and they have hypoplastic arch coarctation. So whether there's always degree of LV underdevelopment, and there's always degree of smallish LV. So if you go for a primary repair, this is extremely difficult. If you do the arch and then bend them, it's also difficult. So would you do like a Demus K and a shunt, or like how would you approach to this group of patients?
Thank you. Regarding the use of mitral homograft, as I did, a big part of my training with Alain Carpentier, I'm in favor of that. And even, many years ago, I published the tricuspid valve replacement by using a mitral homograft. I like this one. Usually, the implantation of the papillary muscles is important. Usually, the anterior papillary muscle should be implanted into a trench carefully done into the interventricular septum, and the posterior papillary muscle should be implanted into an incision done parallel to the posterior descending artery in order to have, enough support resistance to the tensile stretch which will be applied, on both leaflets. Usually I use, this technique in female patients, rheumatic involvement of the tricuspid valve. Regarding the mitral valve replacement using a mitral homograft, I had a lot of cases, especially in cases with acute endocarditis. In some of them, I used the anterior part, some of them in the posterior part of the mitral homograft. Then the other big problem is, usually the European homograph bank stop giving, enough material. Yes, it's very difficult to harvest by preserving, both papillary muscles. Then, unfortunately, in the endocarditis, where you don't want to use synthetic material, and decrease the recurrent rate of endocarditis is a very good option to get out of the acute stage of the endocarditis. Really, the use of pure biological tissue should be, mandatory in these cases, because if you implant a ring or a valve with a synthetic material, it's sure that, you will never stop the endocarditis. Again, the bacteria will colonize, the synthetic material. Even, you have the impression that, you cured the disease, and then many years after, I had this experience, they restart, when the immunological system is down, they start again producing recurrent episodes of endocarditis. And for that reason, I believe in the specific cases are okay. The other problem, in pediatric population, the mitral homograph will not grow up. The second problem at this age, to get from the homograph bank small mitral homographs is impossible. And for that reason, unfortunately, there is for these two main reasons, there is no place for the use of mitral homographs in very small children. Or, you can use, in cases of endocarditis, perhaps, next time in Serbia, I will present, my experience in endocarditis with the use of the mitral homograph. Some pieces of this mitral homograph, there is good results, because you have, the patch tissue, the leaflet tissue, plus, the component of the subvalvular apparatus. And it's, you have very good results.
Brief comments on the mitral homograph. You need to take in consideration that it's also degenerative disease. So that's, we would try to avoid it in the pediatric population. And we would rather prefer to put a prosthetic valve if there's no other chance. For your question linked to the complex AVSD with the coarctation, interrupted aortic arch, so then the approach, it's extreme approach, it's a hybrid, that you can stent the PDA and put the bends on the PAs, and you can wait before you decide whether you would consider the univentricular or biventricular circulation. There's the one important premise. The AVSD is not evolving endocardial fibrinostosis, or that would be extremely rare. So we should treat the AVSD completely differently compared to critical aortic stenosis or coarctation with intact ventricle septum, because even these patients may develop the endocardial fibrinostosis. We published the papers. So we believe that the left ventricle can grow in AVSD. And the option, again, kind of the conventional approach would be to repair the arch, to put the bend and wait. I'm not too much worried about the RVH. I would be more worried about the AV valve regurg, because the RVH is transient, right? So it can remodel once you fix the AVSD. And then we would, so repairing the arch, putting the bend, waiting till 3 months and fixing the AVSD. If the ventricle is small, so I would use the same what I've already told you, borrowing more tissue from the right side. Alternatively, at the time of the aortic repair and bending, we would consider to make the atrial communication smaller, again, to expose the left ventricle for the larger volume, and then to do the corrective surgery at a later stage. The vast majority of patients, the result will be okay. So I would be, again, I would be less worried if the AV valve is bad. If there is the severe AV valve regurg in complex AVSD, that's something that I would be worried on in terms of the survival of all procedures.
Thank you very much.
Just one question, because you mentioned the endocardial fibrinostosis. It is a very questionable issue for me, because I remember one lecture from Professor Bob Anderson about aortic stenosis, and he told it that we cannot expect endocardial fibrinostosis in patients with aortic stenosis if there is no mitral valve stenosis.